Rasha, can you hear me?
Yes, great.
All right, and you can see me, right? As well?
Yes, we can
Okay.
see you. Great
Right,
to see you.
thank you. Thank you very much. First of all, I'd like to thank Boston Scientific for giving us this opportunity. Today, we like to do a rotablation case with you. So, before we start, I'd like to ask Mohammed Hashim, who's from Pakistan, a fresh fellow of me. He will present the case for you. Go ahead,
Okay.
Mohammed.
Thank you, sir. Today we have this calcified lesion. We have 62-year-old of gentleman who presented to the emergency department, not in our hospital, but somewhere else in the some other city of Turkey. He has 20 pack years of smoking. While on ECG, he was diagnosed as an inferior wall MI and shifted to the cath lab with informed written consent. So on angiography, there was a diffuse severe lesion on LAD involving both the diagonals. You can see a highly calcium coronary on LAD. While there was a severe diffuse lesion on circumflex starting from ostium, while as it was evident from ECG, there was total occlusion of RCA from mid-segment. So he was dealt accordingly. Primary PCI of RCA was done, and TIMI-3 flow was achieved. In index hospitalization, he was a stage PCI to circumflex has been done. And meanwhile, as there was the circumflex gets total, but he again rewired and some flow was achieved. Then on the same setting, FFR to LAD was done. As it was looking in some views, it was moderate lesion. So FFR was done, which showed significant. So it was 7.5. So then again, he contacted Dr. Ömer Göktekin for further treatment. So here we have this patient on our table in Memorial Hospital Cath Lab. So this is the plan for today's session, and I hand it over to Professor Dr. Ömer Göktekin. Yes, sir.
Yeah,
Thank you.
right. So let's show you today's angio we have done. Can you come the first image for us, please? So you saw that the RCA and circ lesion already treated, and this is circ, looks very nice. Although the final image of the small circ is not good. After 2 weeks, we have nice circ filling. This is spider view. Can you come back? Spider view, please. In here, what do you think for the ostium of the LAD? It looks definitely calcified, but also there is moderate stenosis at the ostium of the LAD. Do you agree with me in that position?
Yeah, I agree. We'll go around too before you jump into the case. Just going through the panelists here. Shafkat, would you just try and see balloons first and see what happens?
Let me show you. Yeah, sorry. Let me show the fresh angio, and then you.
Yeah,
I like you to discuss this case, and also maybe I can show you the ILS first. Oh, this is long lesion. You know, according to angio, I think there could be a breach at the end of the a lesion. We have first and second diagonal. First diagonal is, you know, sizable, but the second one is good diagonal. We have to take care of that one for sure. Next, please. And it looks very heavily calcified. The lesion is eccentric, I would say. Next, please.
This last one.
Okay. Then we did IVUS before connect you to show you IVUS. And let's see the IVUS first. And then you can discuss. Make the IVUS image the
Bigger one.
bigger, please.
Did you have trouble advancing the IVUS
No,
cath?
no, it was straight. No, straightful.
Yes, blank.
Okay, yes, play, please. This is
the Opticross? Is this the Opticross IVUS?
Yeah, this is the Boston HD IVUS, Şevket.
Rota, bro.
And this is the distal healthy part. In here, the vessel around 3.1. And now we are coming to disease part. not that much calcification here, and we are coming to proximal.
So it looks like they're tandem lesions there. There's one earlier that we just saw, and this is the
Right.
second two.
Right, yes. And we are,
Yeah,
the
a lot of calcium
diagonal is coming, and this is,
Yeah, moderate calcium.
Cranial.
To severe.
Cranial. Önceki.
Yeah,
and
severe.
here we have heavy calcification.
Heavy calcium.
Here is almost 360,
Right.
Mm.
and so we have very calcified lesion. Then we can't see much beyond the
Beyond.
calcification.
Right. So great shadow example of
Yeah,
the
true.
typical calcification on IVUS. And I'm assuming you went all the way to the left main, which we're probably about to see in a
Yes.
second, just to see how significant that the osteal lesion is.
Okay, now the circ will come, and please note the ostium of the LAD. If we cover it or not, that's I think the important decision we have to make. If we stent LAD from the left main or not. This is the circ, and it's just they practice stent. That's just the ostium, which is nicely. So this is left main. Left main is around 5.5. Yes, this is the IOS before rotablation.
Excellent demonstration.
Yeah. Okay.
You can go ahead and let us know where
Yeah.
you're at now.
Okay, yes. So we just here, we did IOS and nothing more. We inserted our Rota wire with help of Mamba Flex, which is a microcatheter we use in CTO. And I use here extra support Rota wire. The reason is we have eccentric plug here, so I thought that is much helpful than flip Rota wire. What do you think in that point?
Definitely, yeah. Great
Okay.
idea.
Yeah, okay.
Do
And
you
we,
typically use it routinely in most of your cases, or you selectively in the ones with very eccentric?
right. So
Yeah.
today we are using Rota Pro. We have Rota Pro, and it's almost ready. I'll show you how we prepare it. We of course connect it with the liquid, and we have to open and make sure if the liquid is coming. This is important to see, and liquid is coming.
Yeah. Professor Ömer, before you move on, just quickly, Dr. Asad mentioned a good thing that we usually use the Rota Glide. That's already a done solution for you in the U.S., but in the Middle East, you do your own. Do you do your own solution?
What as you mean the as operator?
Rota glide.
No, I mean the.
No. We don't use the no. We don't specific fluid for that. No.
Okay.
Anyway, we have in our bag we have 5,000 heparin, 5 milligram of verapamil, and 5,000. How much? 5,000. 5,000 nitroglycerin. All right. So now I am inserting Rota wire into wire port with carefully.
And what size burr you're using?
Ah, yes, that's
Yes,
important
it's
question. Sorry. What do you suggest first of all?
What is the vessel size on the IVUS?
The bend
What's
is-
the distal
It's
vessel size?
yeah, the distal is trio. When you go to the proximal 3.540,
175.
175. Okay,
175 because probably your calcium is mainly proximally.
yeah,
So maybe a 175 per.
right. I choose the same 175. Yeah, because if we can start with the smaller one, but the cost will be doubled. So we choose 175
Directly.
for the one. So when we insert the wire, the rotablator catheter should be straight, and we should aware that not to bend of rota wire, by advancing the bird. This is very important. So now, did you have the wire there?
No. Not yet.
And Ömer, can you give us some insight about your setup? Is it a radial procedure? Are you doing it radial, 7 branch, 6 branch, 8 branch?
Press.
How is your setup?
Bas oraya.
Sefer French.
Yeah, sorry. We are working over 7 French EBU by radial approach. Okay, a little bit more.
Yes.
Okay, here, stay
Yes.
here. We will do some control. And now I insert my burr. So, where is wire clip? This is wire clip is very important tool. Before testing, we should, wire clip should be set at the end of the wire. Otherwise, when we do test, the wire will be king. Right, you can leave this wire clip over the table, or you can set it at the docking port, which we will do.
Yes.
All right.
Keep it
So
straight.
now, yeah,
You're going to do a test
then
run?
we push the advanced knob to start rotating burr, and we will see it,
Yes.
and we will test it. I like to have 185,000. It could be 180 to 190 RPM. Let's do it now. Can you show the camera?
The device.
We would like to see
Keep the device to
the
this
proximal part of the board. Can we see the proximal part of the board, please?
Yeah,
Yes, exactly.
yeah, okay. Make it 185, Elif. All right.
We would like to see how the fluid is dripping.
We have to make sure, burr is smooth rotating when back and forth. Okay, stop please.
And we always want to make sure that the burr is not touching anything.
Yes,
So-
anything,
Yeah.
right.
Yeah.
So we have to be aware not to wind anything in rota burr. Yeah, very important during the test. Before we insert, we have to insert advanced knob, like to the ahead of the rail and by 2 fingers, to get the room for pulling it back. So it's like that, 2 fingers width. We are ready to go.
Yes, keep it straight.
When we go inside, you are ready?
Yes,
Okay.
I am ready.
We like to have dyna mode. Okay, we activate the dynaglide. You see the screen we have in the dynaglide. Show them.
Any
And
comment about the dynaglide?
Yes.
I don't use a dynaglide for going in.
Yeah,
What
we-
about you, Esad?
all right, yeah,
I always do. I always press the first pedal on Dynaglide
Alright.
before even starting burning. So I always go up and come out both on
Yeah.
Dynaglide. But I
I-
don't go on activated Dynaglide going in.
all right,
Yeah.
That's what you mean.
all right. It's a bit depends. Also, we keep the
Just
brake.
makes it easier probably. Yeah.
True, yeah. Also, we keep the brake unlocked while advancing the burr. That's important
Yes,
issue.
it is.
All right. So we are in the dynaglide and insert.
Yeah,
please.
insert.
Yeah, go ahead. Now wire is coming back at the end. You see.
Proximal.
Yeah, go ahead.
Proximal.
Yine biraz daha gidelim. Tamam. Biraz daha git. Biraz daha gidebilirsin. Gidebilirsin. Git. Left mane'e gir. Tamam. Okay, stay. Yeah. Okay.
Stop.
So now we are in the almost left vein. I didn't go. I could go a little bit further, but let's start from here. So we are ready. Before start, I'll come back at the end of the rail, like this. Do you see my hand? Yeah. Okay. Now we are ready. So we have to advance the burr up to the platform enough a part of the lesion. We have to make sure we didn't, start the lesion. We didn't, occlude the artery. This is important. Now I dynaglide off.
No.
Okay, let's start. Dynaglide off. Do you see the screen and everything, guys?
Yeah,
Okay.
we can see your hand on the Rota and we can see the angio as well.
So we have to push gently. Now I don't have any resistance so far. Each round should be around. I have some resistance here. If I have light resistance, I can push forward. Okay, stop.
Now you are through.
About wire. Keep wire.
So I come a little bit back. We have to
Can I
do
push
yeah.
my wire?
Yeah.
Slowly.
A little push gently. Yeah.
the rota wire should be as deep as it's possible.
Yeah, I will insert it a little bit more with Dyna help, okay?
That's a good trick.
Yeah. So anyway, let's push a little bit forward, and I'll do a little bit more. Each time, each run, it has to be 15 seconds. So our pressure is okay. We can give some fluid here. Okay.
This is nice.
Definitely a change from the first one.
Okay. Another run, and okay. Okay. We, you know, that's important thing that we have to park our burr at the end of the rail. Okay, not the middle or the other eyes. You know, you have to come back at the end of the rail. I think we did our rotablation. Let's do another pollution,
Iris.
and then yeah, we finished it. Yeah,
Are you going to do another iris?
I will do Iris again. Yeah, but after dilatation with the balloon.
So it would be very interesting to see what the Rota did to the eccentric calcification there.
Okay.
It would be very educational.
Right, thank you. So let's go with the again with the dial mode. We will remove it by pushing the wire. I'd like to show you how we do it. Okay.
The Y connector should also be opened. That's another thing.
Yeah, press it, please.
Important thing.
Scopy. Yes.
The dyna should be pressed till the burr comes out.
Yeah, it's
If you
dyna
do it-
glide
if-
mode. Yeah.
If you do it early, then the burr gets stuck again in the wire. So you have to pull everything
have
out.
Yes.
Okay.
Yes. Exact. Stop.
Okay. Have now. Let's do one injection. If we have anything wrong, everything looks okay. But let's check it again.
Yes.
All right.
Yes.
All right. Did you? Now I'm sending microcatheter. You know, I know. You know, the wire is very important for the operator. We don't use this Rota for the stenting ballooning, right? So we don't know. We don't use that much. But other wire, we know everything about them. How much they tire. You know, how can we use them? So we don't know. If we use it, we will use it several times in a month, the best. So why I use this?
I agree. I just wanted to know whether anyone do it.
Come on.
Would anyone do it?
Okay. So over the inside the Mamba, we insert workhorse wire, which is choice, and we will do dilatation before IVUS. We do trio dilatation.
Scopy.
Yeah, trio. Before IVUS, we do trio dilatation. But before dilatation, I like to insert a wire to big diagonal, because after dilatation, I might have a dissection, and it will be not easy to go this big diagonal. What do you think? I think it's time to rewire it if you wire it.
Wait, I would protect it, yeah.
Yeah.
It will be very exciting to see you how to wire that diagonal.
Okay.
Are you using an NC balloon now?
Sorry,
No, this is, we are removing Mamba catheter, and I'd like to have another choice, please, for side branch. And we will keep it open for the first diagonal too. So our bunu kullandık mı canım? So we give
So
two
in terms
two
of the side wire, the branches, like, do you always take the workhorse wires, or do you sometimes use those coated wires? Because obviously people are divided on it. Some people think that you might leave the coating behind the stent. If you leave it jailed, the other people might find it doesn't break that easily, so they prefer wiring the side branch with a floppy wire, a more hydrophilic wire. Do you have any preference, or do you always use your workhorse wire like a BMW or
if you ask me, Asad, I don't use hydrophilic wire unless I need it. You know, if I needed this, I use, but I don't need. I don't use it if I don't have to use it, because hydrophilic wire is you know, very very slippery. We have easily remove back, and we have risk of easily going intraplaque, and we have
Cranial.
risk of dissection, I mean rupture even with the knuckle. So if I need it, yes, I'm using it. So shake it.
That's it.
But this was so easy.
Yeah.
So I don't
No
know why
fun.
you are wondering.
No fun at all.
You know, this was the easy
That
already.
will look tricky, but it may
So
not be.
let's do another one.
Another wire.
Or let's do another
funny
one.
when I see you
Tell-
struggling,
tell-
not
ask
this
her.
one.
Right.
Who
Let's write the first diagonal, right?
Tell.
As well. Now.
So what do you guys do in terms of if it's an
Göstersene.
RC, do you
I'll pick
still
one.
use pacemaker or do you do aminophylline?
Can I get the question again?
So if this was an RCA, would you go with pacemaker or aminophylline nowadays?
The question goes to who?
If you're doing a rotational atherectomy in an RCA,
Goes to you.
When you don't know the answer, you asking who asking who? He's asking
well,
you.
She's asking everyone.
He is asking you.
while you're getting
Okay,
this,
she's asking me. So I do both. If I see a long lesion where I see there is going to be a very high likelihood of
Epicardial?
slow flow and stuff, I will probably preferably put in a temporary pacemaker. If it's a short lesion, I can get away with short runs. I will try to avoid pacemaker. So I'm not 50-50. I haven't totally moved away from a temporary pacemaker yet.
Yes, please.
Yeah, by me it's up to my mood. If I want to go on very aggressively, and if I want to work in a more aggressive manner, then I definitely go with the pacemaker. If this is a big RCA, and if I'm going there with 2-0 burr and want a debulking rather than modification, like a more debulking, then I would go with the pacemaker. But usually when I go with the 1.5 burr, then if you work in patience and if you work very slowly, you don't need any kind of pacemaker. Of course, you should always be looking at the pressure and at the rhythm. That's the key.
So essentially both, like you haven't really moved away from pacemaker completely.
Yeah.
so walk us through what you have there. What balloon do you have in there?
3.0 15 quantum overic, right? Let's touch here too, yeah? We have to be
But this
careful.
is an excellent balloon.
Go,
This is an excellent non-compliant balloon.
I think we have to cover all the way right up to here.
Fine.
Down.
Why don't you have the thinking of using some kind of scoring or cutting balloon? I'm just curious about.
I use already Rota, which is okay for me.
Enough.
If I couldn't
For you.
open it, then I'll try
Yes.
maybe
balloon.
cutting balloon. Yes, we may need it to be honest. Yeah, I agree with you. But now let's try with the NC.
So
okay
open nice if this is one of the lesions.
It's opening nicely, but before inserting the stent, I like to go at the proximal part. I like to go with the 3.5 down, up and down.
But also
16, 20.
Shevket, if you look at the proximal
20,
part of the LED
down,
where most of the calcium is, he actually has 3 wires. So even NC will work like a scoring balloon here because
3.5,
people have
15.
2 other wires around it. So
Yeah.
it might work as a
20.
scoring balloon.
20.
Yeah, poor man's
20.
scoring balloon.
Always.
Yeah, sort of. Poor man's scoring. And he already said he's not rich.
Wow.
Yeah.
Ruptured.
No problem.
What time? What is it? So 3 or ruptured at 20, right?
Yes.
Okay, go up. This is 3.5. Yeah, go up. Yeah. Okay. Yeah.
You see, the balloon is going
Yeah.
around the calcium. So
Yes.
I
So-
think that's a sign of deep calcium. So that might be the reason why I wanted to use here a scoring or a cutting balloon.
Yes, go up.
Oh, I might use cutting balloon here.
Yeah, cutting balloon probably.
If it's now open.
No, good opening. No.
What do you think? Is okay.
Yes,
Not
sir.
sure. Not sure.
This
to be-
part good, but the proximal part needs some kind
Not
of
sure.
more
Try
modification.
it again.
Yeah,
Yeah.
go on.
That's
Go
where
on.
most of the calcium was on Iris.
Yeah.
Okay. Yeah.
But we skipped that part already.
No,
there's
I
still
think
something-
I'll do cutting here.
Yeah, cutting would be better.
20. Ne var? 3.5. Cut. Or scoring. Cutting or scoring.
I think
This is a Boston session,
Okay,
so we're
yeah.
gonna do a Wolverine, I think.
yeah.
They don't have the
Which
scoring
buçuk?
balloons.
Yeah, I think you
Okay.
don't
Yeah.
sort of
No, no.
scoring different
Cutting.
things.
Altı çok kusur.
Okay. 6 is okay.
Yes.
Yeah,
maybe.
Six,
Yeah.
six is okay.
Yeah,
Yes, yes.
3.5, but 6.
By
We
six,
have
yeah.
flex tone cutting.
I'm not on the screen anymore, but we
But
can
I
do
think,
it.
guys, it's important to see that part is not that opened well, right? This
Yeah.
is important.
Right, there's a bit of a waste. It's
Yeah, yeah. That's why I like to touch by 3.5, Rasha. If I would go directly stand after 3,
Yes.
I wouldn't
Not
see
good,
that.
Expansion.
Right, you're right.
But it's
And also in terms of sizing your cutting balloon, like you knew the vessel size was around 4, so probably 0.5 smaller will prevent
Yeah.
any major dissection. So
Yes,
probably great
good.
sizing.
let's
What's your maybe a distal wire LED one?
here. Okay, go up here.
We have to do something for diagonals.
Yeah, that's okay.
More?
14, 10,
This is also
10.
interesting to
Go up to
see.
10.
We have a wire there, and we are
10, yeah.
cutting
You can go.
also
12.
the wire somehow.
Do you think so? It's possible?
Yes.
I don't know. We will see.
Yes, now it's okay, huh?
Interesting is
Is
with
it
IVL,
okay?
we can
It looks
do
okay.
Yes.
Down.
wide, and it wouldn't
Ay,
affect this. I wonder if it's
hemşiresi
a-
başında.
Maybe from diagonal.
12, 14. Yeah, we need to have
Yes, yes.
pain, huh?
Yes.
The IVN option is always off.
Yeah.
Here.
off
I
the
think we
table
are
for
okay
me,
here,
so-
right, guys?
Yeah. This is good.
Kaç yaptın? 40. Okay, let's see. I think it's okay now.
I think more proximal we should do it also. You see the proximal part?
Yes,
It needs
definitely,
also.
yeah, there was
It
a lot
needs
of
also modification.
But you
proximal
see,
part.
I'm losing diagonal. Maybe we have hematoma,
Fracture.
hematoma there.
Yes.
I think more than plaque shifting, we might have hematoma. After dissection, we have to take care of the diagonal, and I think we will stand that.
And so on.
And guys, I like to touch with the 3.75 with that lesion once more, and I go diagonal. What do you think?
Diagonal first, yeah. You should definitely balloon the diagonal first.
Yeah, balloon it first because there's no flow there. It's probably
All
gonna
right,
start
okay,
shorter.
give me 2.5
Yes.
balloon.
Yeah,
balloon.
and see, yeah.
Yes, go up.
You are.
Let's see. 10, 12. Okay, him. 12. Down.
Yes, good.
Bir filme gidelim.
Let's see.
So, it looks long lesion, right, guys?
Yeah,
Yes, more distant.
maybe balloon a bit distant.
I don't like the feeling of the LED.
Yeah.
Okay, go up here. I think we have to be a little bit, hurry.
Quick, yeah, maybe
Right.
start
Yeah,
standing.
down, yeah.
But with the calcification,
Up and
I
down.
feel a bit more safe than without calcification. You
Down.
have some kind
Down.
of skeleton
Let's measure it.
around
Let's
the
measure it.
vessel. So it might to give you an opportunity to go out
Okay,
there
yeah.
without stanting, maybe.
Okay.
Okay,
So,
okay,
how,
okay. This is 15.
15, 28,
Yes,
is it fine?
23 or
28.
Yeah, would
28,
you
yes.
stamp that diagonal?
Yeah, I will do it. Yeah.
Nihat, what do you think? Nihat would leave it
No,
without stamping.
no, I don't think so. I can't lose this diagonal.
yes,
Yeah, no, it's already.
I don't know what's happening there. I think I have a dissection because it's enlarged
yes,
a little
sure,
bit.
Right.
Okay, go up here. This is yeah,
Go on.
14. This is 375. 20, 24. 24.
Yes, yes, enough, yeah.
I think that's fine.
Yeah,
That's
yeah.
fine, guys. I don't know.
We have some curve here.
Down. What do you think?
Looks better. Looks better.
Looks acceptable. Yeah.
Yeah, better.
20.
Much better.
Go up.
20. 20.
Wait.
Down. Okay. I like to have two. I think we
LED.
can put 2
This is
pi,
diagonal.
2 5,
Yes.
and we can go.
Go with.
Just a second. We can go with. Let's see again. Can I give? Yes. Can I have some nitro, guys?
Yes,
But
we
pressure
can
is
do.
okay.
Everything is okay.
We have dissection for sure. So tell me 275 or I think 25 is good. Then I will extend it 275 anyway.
Yes, yes, yes. This is the
Flora.
one, two.
Okay,
this is the
send it
diagonal.
please.
Yes.
So obviously this is complex lesion. You see that we have issue with the diagonal. We didn't touch it, but still we have issue. It could happen. And our ACT is good because it was 300 and we give 2,000 more.
Ufak.
Oh, all right.
So you have 3 wires. I think you should pull the first diagonal wire.
I want to see the
The
stent.
wires
Fluoro?
are entangled.
It's a small diet.
Yeah.
Okay, I'm not
We
sure.
are in the circ stand.
No, I'm in the right position. No.
To the lesion.
Not easy to
And-
pull. I have to be careful regarding pulling my,
Ah.
yeah.
Yes. They are out.
And I have some deformation at the proximal part maybe. So,
I think the problem
let's
from the
insert-
circ stand.
yeah, let's do something.
Mm.
Let's insert this first, if we could.
Maybe you need a balloon. Small balloon.
I'll probably maybe take a balloon with a guide liner, try to go beyond that circ,
Negative. Yes.
also interference
Yes,
with
yes.
it.
All right.
From here.
If I insert this,
Oh.
which is not easy, this is big balloon.
Yeah.
I like to anchor it.
Yeah.
I'm
Yeah.
afraid that I lose the stand because the proximal part, it happens to me some time ago. Which is stand?
Stand is here.
Can you retrieve the first diagonal wire? It will help you.
No, I mean, now my issue is pulling stand into the guiding, Şevket.
But you can't do that now. Oh.
Because I have, I have
No,
issue.
Yes.
Ah, okay.
You see?
Yeah,
Like
this is.
Made it.
Sold, enable
Back
guidance.
into the guide now, huh?
Sorry, no.
It's not.
Göster box, no?
Let's see if the stand is okay.
Yes, stand in the position.
It's okay.
Yes,
Let's
it's
see.
okay.
Are you sure? But why? Okay, let's see.
Still
Let's
on
see.
the balloon
Let's see.
at least.
If you can't do that, maybe you have to pin your balloon to the stand and then remove the whole system. That would be safe, I
Yes, this
think.
panel.
It's
Let's
not. It's a bad option, but
Let's
the
see.
safe one.
Let's see. I'm happy if I remove this stand,
yeah.
which I don't know. Let's see.
Like it
It's
moved.
already in.
Sure. No, I don't think so. It's
It
here.
is here. It is here. We need to remove everything now.
It's
Yeah,
okay.
yeah. Do it. The safe phase is
But,
important.
it will be
Pin the balloon to the stand, and then remove the whole system.
small balloon in the stand.
All right. Look at
Nihat has always some solutions for such kind of things. Nihat, what do you think? What should we do?
you know, everything, guys, everything happens on your, front of your eyes. I didn't push that much. When I feel it not crossing, I try to pull it, and I don't know why it happened.
What's the brand of the stand?
It's distally. It is not in the guiding.
The stand is on the wire now, and it's outside the guiding catheter.
Yes.
Wow.
So the best option to
Snaring,
have
maybe
snaring from the
Yeah.
from the
other wire.
proximal.
Come back. Back to it.
But first of all, I like to treat the vessel.
No,
Okay.
It will stay.
You want
I-
to push the wire in a bit so it
No,
Takip
it's
it, takip
okay.
it.
stays on the
That-
wire?
So let's. Yeah,
Yes.
I can have it. I don't think I can have it in my sheath,
Yes,
right?
that is a problem, yeah.
It's already damaged. So what we do? I can snare it from here,
Yeah. You should snare it.
and yeah, let's
We should
snare
snare.
it from here. Okay. It's a
What,
big.
what's the brand of the stand?
See?
Zions? Promus?
No,
What
It's
is
the
it?
biomatrix.
Biomatrix.
Thing.
All
Yeah.
right. So let's have a snare.
So we are so relieved that
Küçük loop.
when this happens, we will not regret it. Ömer, when this happens to us, then we will not regret it. Even Ömer did this, even in a live case.
No,
so-
but no. It happens on your eyes, okay?
Yeah.
In front of your eyes. I don't think we did that much aggressive
No.
behavior. So
It's not on you. It's not on you.
no. I mean, it could. Yeah, sometimes I could force more, but I didn't. I'm saying that. You know. So listen.
En küçük. Ha.
I think the third wire was entangled with the other wires. And by
No,
pushing-
it's not the issue. It didn't cross. Maybe there is twisting, but I could pull it back nicely, right? So actually, it happens to me some time ago.
Me either.
Do you have it?
Yeah, of course. Everyone had it.
Yeah.
No one confess it. It is coming, that's it.
I don't think. Not
Be
easy.
careful because the wire might be off of the stent at this point.
Right.
Uh-oh. I think you're losing the stent. It's coming closer to the tip now.
That's okay.
Yes, okay.
We should do it the other way around.
Yes. Keep.
No, it's not a problem.
Oh, it's going
Let us remove
forward.
this for you. Yes.
Yeah.
No, it's coming with the flow.
With,
I will catch from maybe
got
other
it.
side.
Yes.
Yeah.
Now it's
I did it.
Okay,
I think
let's
I
go.
put- yeah,
Okay,
okay.
Big applause.
Guide it. Guide it.
Yeah. Let's have it.
Excellent, you got it.
It's
Yes,
here.
It is here.
We catch it. All right, let's go start the game again. Fire.
Tell.
So, can you tell me the ACT, guys? How much the ACT?
Okay.
ACT is important, yeah.
It depends on what it looks now.
Test, please.
I think that the diagram is open. I don't think it's
Okay.
it's
Are you
gonna be
cranial?
a problem.
Spider, please.
Oh, we have some. No.
What?
No problem.
You see the diagram is good?
Yes,
Yeah.
we know there is a proximal.
Of course, there will be dissection, guys. What are you
Yeah,
thinking
yeah.
about?
Yeah, of course, of
Once we
course.
secure the LED, I think drag we can deal with it here.
Yeah,
Of course.
yeah. Except I don't think it will help here. It's not class. It's
But
calcification.
it's dissected, so it's
Let's focus on the LED first, right?
Agreed.
Yes.
Yeah.
How's the
Yes,
patient
yes.
doing clinically?
I can regain diagonal. I can regain diagonal if something happened.
Yeah, afterwards,
Yeah.
after
Alright.
the lady.
I'm lucky that I can cross diagonal. Okay, another wire. This is go to diagonal,
Oh, good.
which is okay.
Yes.
Distally, I like to put say trio balloon, trio stents, approximately 3.5, and I will expand 3.540.
Why didn't you use
What
the circ wire to put it back into the LED? That way you don't have too many wires.
Say again?
Do you want to use your circ wire back into the LED now instead of a third wire?
The circ wire?
You have another wire in the circ now.
Yeah, I like
Yes,
to
yes.
have it
Three wires,
because
yeah.
yeah, I
Biraz
don't want to go
torque,
deep
torque.
engagement first and second.
Çok ihtiyacı
I don't. If something happens to LED, I want to. I don't want to lose circ as well. So let's skip circ.
Cranial.
Because we have
Fine.
some kind of dissection there and we
Yeah, it might go
injected a lot,
easily
so
to.
so
It
the
might go
hematoma
easily.
may go backwards and
Good.
it will
Okay,
cause some
now
kind
we
of-
back to the work, guys. That's okay. Let's see one shot,
Yes, what's
please.
wrong,
Yeah, and then see.
beautiful.
Yes,
All right.
we are
Definitely, we have to take care of the diagonal.
Yes, let us.
Let's do
go on the same
diagonal.
plane now.
So I don't think I have a twist now, Rasha, because I crossed the LED, the latest. So that's okay, I think. I don't think I twist them. When I tried to go, especially for maybe, it was easy to cross both art diagonal. I didn't play that much. I don't think I have a twisting anyway.
The pressure is good, the patient has no pain.
No, pressure
No,
is
no,
good.
pressure
Do you see
is
the
stable.
pressure? Pressure is good. Pressure is
Pressure is good and pressure is stable.
140.
Yes.
The LED is there anyway.
This is diagonal.
So we have a lot of time, so you can
diagonal.
walk in peace. You
Yes,
don't
yes, of course.
have to go very swiftly.
Yes, I use Godliner here, Godzilla. Do you have Godzilla?
Of course, Boston is there.
You know, there is lots of calcification, and we break the calcification That's why it's not easy to insert stents. That's the reason.
Yep.
Okay, 12, 14, 16. Down. It's really complex case, huh?
Yeah.
10,
Way
12.
harder than what it
14.
looks.
Yeah. But angiographically speaking, I would definitely go, even if I didn't have any kind of, I would definitely go with the Rota
Stand.
in this
Stand.
case.
Stand.
Hazır.
Now I'll do cloth, guys, here. Cloth, okay?
What size stent are you using now?
Yeah, 2.5, sorry, yeah.
Yes, remove.
All right, let's see. Small injection, not
Yes,
much.
Yes.
We have dissection there. Very gently. Very gently. All right. All right. This is
Yes,
nice.
yes.
2, 4, 6, 10, 12.
Stand.
2, 4, 12.
Because
Mini clot.
I do mini coat, yeah.
Yes, yes.
Yeah.
So go up more.
Okay.
Go 18.
18 yes.
18.
Yes, good opening. Man.
Okay. Show me that. I don't like the proximal part. The proximal,
Yeah.
what do you think?
It's not opening.
Okay.
Go up.
3.5.
Do you want to take an
Which
NC
buçuk
first?
NC?
Yeah, yeah. 3.5 for pot, yeah? No, 3.75.
3.75. NC.
3,5 aldım ama.
Tamam. Tamam.
It's very frustrating when somebody is talking around and if you are walking, but Ömer is very used to it, so I think he will not be
3.75.
angry with us
Masadaki.
Ver.
İyi mi?
İyi durumda
İyidir.
ama sen
if I am not teasing him.
What did you say? I didn't hear you. What did you say?
You are doing a very good job. That's what I'm saying.
You know, I have lots of problems because you said lots of good things to me. That's why I had these issues.
Yeah.
Yes. Test,
Yayını kapatabilir miyim? Bir saniye.
test, please. All right.
It's good. Yeah.
I do. Yeah. Okay. Go up.
Go
10,
up.
14. 14.
12,
14.
14.
20.
But good opening. not
That's
bad.
okay.
Yeah.
Opening is okay. Down.
Yeah.
Hocam asetamol izin verecek misin?
Tekrar
All right. So what we do, what I want to do, I'll remove this diagonal, and I'd like to recross it with this wire. So I hope I can do it, inshallah, and then I'll have a nice way to go down. Or I have still chance to go, maybe crash. You know, I have a wire in place.
Ha, izotonik alabilir misin?
If I have to. If I have
Proximal.
to.
Brox.
When you try to in Godzilla, you have to see the proximal part that you have to make sure you are in.
Right, right.
Sometimes it's tricky. I
Yes,
I
good.
think. Let's see. Okay.
Yes. Yes.
That's important that I follow the true lumen. I
Yes.
might have easily. That's why we shouldn't use here hydrophilic wire. All right.
yes.
Very nice.
Yes. 14.
6 kredimen alabilir miyim?
16, 18, 20.
Yeah.
İn. 3.5.
Uç baş.
8 masada var Nil.
Tamam. Yok masada.
Ver bana. Trio 28 and then 3.5. I like to put the first stand under diagonal, below the diagonal, sorry. Yes,
yeah.
go up 12, 12,
12'ye.
down.
Now, the size of stand.
Yeah. Buraya up 20. 3.28. So
20 mi? 12'ye.
28. Down.
Down.
3.28.
Stand.
Get into trouble. So making sure you have all the equipments in the lab.
Let's see if I hit.
Or if you are not an experienced operator, you can look at the angio and say that I am good, I am cracked with no compliant balloon. But if you're an experienced operator, you will understand how difficult it can be. So then you plan accordingly.
More.
Here. Yeah.
Yes, here.
Okay, up here.
Yes.
14.
10, 12,
And we have to make
12,
Yes, good.
14
14,
down.
Yeah, I agree. I think longer stunts to make sure you have enough room for pots if you need to go back to the circ. All of this will.
That's okay.
So hopefully we'll see at least this delivery of the stunt.
Yeah. Yeah.
What was
4
again?
minutes. 4 minutes to go.
4 minutes, correct.
You don't want to see
Yes,
the
this one is
results?
Okay now.
That's okay. I
Yes.
cover it.
Yes.
I like it.
Go up.
12.
Shish, shish.
Do you
14.
have enough overlap there?
Yeah, I did.
We don't have.
I hope.
The circ. No problem.
I think we did, yes.
12,
12, 14, 16.
Looks really nicely expanded
Down.
here. So
Yes.
this
Yes.
tells you you've done a good
Bring
way.
attention
Good.
to-
So I like to have now, guys, 5-0 balloon for
5-0
pots, and then
5, 0, 8, 10.
I
We go to
recross
diagonal again.
diagonal, the circ. But I do it later. First, let's do pot at the
Yes.
left main. And I can remove, I think, my Godliner, Godzilla too.
Yeah, that will make it simpler.
Aslında 2000, hayır
Evet.
8 dakika önce 2000 ekledim.
Everything
Okay, you see that how much Godzilla helpful, extension guiding helpful for us.
Yeah.
Without Godzilla, I don't think we could do this. Because the reason is, we break the calcium. There are lots of calcium and plaque. You know, they block our way to go down. Okay, let's see. Pressure is okay. 140 again. Okay, let's do here. Yeah, go up here.
Yes.
10. Down.
More distal.
I should have to go more distal right. And I'm happy that the circ
Hiding.
Yes, go
stent is covered ostium.
up. Yes, here is okay.
Yeah, it's
Go up.
it is good.
Go up.
Yeah, go
Go
up.
up.
Yeah. 10, 12.
12,
Okay. All right. At the end, I recross and I'll do kissing for sure for circ. But
can
let's
see
let's
cranial
focus on the
Diagonal and LAD.
recross the diagonal, do kiss and then do pot all the way.
Let us see here both and the cranial one.
Okay, see here.
Circ is okay.
Okay.
Cranial.
Now we
Nice.
seal the dissection.
Calling on it.
Everything is
LAD looks okay.
Yes. And diagonal
Great.
okay.
And opening is not that big much bad,
Yes.
that part.
Tell.
LED looks beautiful. Very good.
Yeah,
So
and we do 275 for diagonal, okay? For post for
Yes. Tell.
yeah, 3 will be big, 2.5 small. Okay, let's have another
Wire.
wire and 2 balloon. So this wire is used wire, not fresh one. Okay.
Nice.
Now 2.0 balloon and
Çalışıyor mu? Ah.
yeah, okay, down.
Down.
Okay,
Şimdi
275
2.75
for diagonal and
Or uçmuş.
um,
3.75.
yeah, normal.
Oh, I see.
Bu ne bu?
Bu 2.75 diagonal. 2.75 diagonal.
Maybe low pressure on the 3.5.
Yeah, I agree.
Then high pressure proximity.
Gently, nicely, yeah.
Gently, yeah, exactly.
Uç. Yes, good.
3,5 veriyorum.
So this is the 2.5.
275.
2.75. Yes.
Please.
Yes.
Geçti.
That's right.
Good.
What was
Okay,
again?
let's do gentle.
Yes.
Go to 8.
Biraz
Yes,
daha.
it is enough. No, yes.
Go.
Here.
Yes, here
Go.
it is enough. Yes. Go up.
Let's
Go
do
up.
small,
8.
slowly. 8.
6,
Probably
Eight.
stents.
Okay. 10.
10,
Yes, it is enough.
Stay. Down. Let's
Down.
see. It's became bigger. Let's see what happened.
Down.
Go up here.
Yes.
10.
10,
Down.
Yes. good here, but the
But
proximal-
easily expand. I don't like
Yeah.
it that
Here,
much.
here. Go up,
Ağrısı.
10, 12, 10,
because we have two balloons. No
10,
balloon.
10,
12,
12, yeah, 12.
14.
14,
It's okay.
Yes,
It's okay.
now it's okay.
Down, yeah. Let's do kissing and let's
Yeah.
see the result.
kaç?
14,
16,
16.
down.
See,
Okay, 16.
yes.
Down.
Down, LAD. Direct.
Well, diagram.
Okay.
They didn't do the simultaneous kissing, so I asked them again.
4,
4,
6,
6,
8,
10,
10,
12.
12,
1, 2, 3, down. Okay, let's see what we have here.
Keep the balloon on the wire on the LED. Then just
Okay, this is good.
Very nice.
Okay, okay.
Yeah.
We can do 4.
4. I will do 4.
Yes.
Yeah, LED looks great. So
Yeah,
diagonal
we
color.
open. Yeah, we break everything there.
4,
Fuse.
Bekleyin.
Evet, evet, ya.
Y,
Okay, 4 3.5. Okay.
Hocam Y kapatır mısınız? Kapalı.
Yeah.
Yes.
4, 0 falan.
Let us see here. Yes,
Let's
exactly.
do it here,
Yes,
right? Okay.
No.
10, 14.
10, 12,
This is the most
10.
difficult part.
14,
Kaç?
Yeah.
Okay, down.
Üç buçuk.
14, 16. 3.5 ver bana.
hazır.
16.
Ver. Niv değil mi bu?
Yok hocam masadaki. Ne alayım mı?
Okay.
Taşıyorum.
Bunu da şişirelim. 14,
Şişiyorum. 2,
Şiş.
4,
14.
6,
14.
14.
Down. Go up 20.
14,
20.
16, 18.
Now we do
Now
kissing.
Yes.
Wait a little bit and then
Yes.
kiss. Yes.
Yes. Go up.
2,
2,
4,
4,
6,
6,
8,
8,
10,
10, 12,
12,
14.
1,
1,
2,
2,
3.
3.
It's nice kissing.
Şuraya ya.
Ah, you see that part? Still we have some eccentricity. See what I would says. AP cranial. Bismillahirrahmanirrahim.
Yes, we need more.
Yeah, it's okay. I don't think we can do bigger that
Yeah.
part.
That must be, I agree. That
I
must
can
be
have
great.
I can have a rupture if I go
Right.
with the 4.5,
Yes.
and I don't think I need it.
Yes.
Yeah.
Big vessel anyway.
Is it enough?
This is
Kaydı benim sayfam.
Okay,
No,
let's
it is
see.
enough, it is enough.
if we can have the screen on the
1 millimeter.
Yes,
Okay,
yes,
you
it's
see the IVUS. Okay, yeah.
Yeah.
Pull back, please.
Perfect.
Recording, yes. Okay, we pull 1 millimeter. This is a big
big
septal.
vessel.
Big vessel,
Yes,
yes,
now
yes.
stent.
Big vessel. And stent is
Very
nice to
nice.
oppose.
Very nice.
I think 3.5 a good choice for
Yeah.
post dilatation.
I agree. Maybe that segment you can hit
Yeah,
it
please.
one more time with a 3.5
Yeah,
again.
this is all very calcified
Yes,
lesion,
yes.
but not
Look
bad.
here, they
This
expanded.
is just below the diag.
Yeah, yeah, just before, yeah. This is eccentric. Which part is this?
It
Yeah.
is the middle.
Yeah, middle. This is the
first,
middle.
Just below the diag.
Now,
Yeah,
now is
get that.
opening is
Sınav
okay.
aldın mı sen?
Aldım.
And you can probably
Particular
check the MSA if you hit it one more time with a 3.5 and a 4.0 proximal. This looks actually really good, by the way. This
Yeah, the proxim. Yeah,
hard
that
part,
part
yeah.
was good. Yeah, I agree with
Yeah.
you. That part was okay. Yeah, the proximal part for
Is
I
enough.
think good size. Again, another eccentric opening
Yeah, you can probably
because yeah, we have a dissection here
Some
and we have
hematoma.
heavily calcified lesion, and this is the left main
Left main, yes.
550.
Overall, yeah.
Yeah.
Overall, very
Yes.
excellent.
Nice.
Even
Yes,
the
stop.
very, Just hit maybe those two areas and then.
Okay. So do you want me to hit that part 3.75 or because
Sadece
I think 3.5 at a high pressure. We
Three
went
se-
like to 10 only.
sorry? Yeah.
3.5 with a high pressure.
Yeah, but
maybe.
that part, no, that part we did
we
nicely.
did 3.5.
Yeah, that part done nicely.
It was
So-
still below the diag. I think below the diag we just went to 10s, no?
No, no,
Just
no.
above the diag
No,
we
no.
went high pressure.
No. Just at the once I went 10 and then easily I went 4. Let's see.
Let's see.
If you want me 3.5, it's better for me because then it's the risk is less.
Yeah, I know.
And if you will be happy, that part, you see
Yes.
that part, I did it. I hit it
Yes,
3.5 big balloon. I'm sure. Let's do. I mean, we can do again once more.
I'd probably
Maybe
take
high
that
pressure,
short
3.5.
375.
375.
Yeah, 37510 or shorter.
Okay, let's do. Let's
For
do.
that second.
We have, if we need that, we have
We have in the
graft stand anyway. We have 4, yeah.
Nasıl?
Okay.
So for the sake of time,
Or
I
we can
think
go
we,
do again 3.5 but for more
3.75 alalım.
3.75.
3.75.
Salon masada var ama biraz
Okay. Bu kaç bu?
So,
3.75.
I think in general, first of all, you did a really great job. It's really tough lesions throughout the LAD. Great job handling the complication, and you've demonstrated all tools in terms of the calcium modification and how you handled it very well. These things sometimes, as you mentioned, you would see an area that's underexpanded, or in this case, the stent itself expanded to 3.0. It's just the calcium on the one side. So hitting it one more time, maybe with an NC. If
Let's see.
you already have an MSA of 5, greater than 5.5, I think you leave it
Yes,
as
good.
is.
Let us see.
Just here. Okay. Go up. Yeah,
Yes,
here.
exactly, yeah.
Okay. 14. Let's do 14.
10, 12,
14, yeah? 14, 16. Okay.
16,
Okay. All right. Okay. Okay. That's good. It's open.
Yes, yes. It's good.
Yeah.
Hopefully. Let's see. Okay, let's see. Right.
Yes.
So,
Nice, yeah.
yeah, I mean,
Weak oils a bit.
yeah. So I wouldn't go more.
Yeah,
I
I think
agree.
we've done enough.
No, we will have rupture for sure
Yeah.
agree.
here. I'm sure. You know,
I think tracing it, I'm pretty sure you'll get an MSA
Yeah,
more than 0.5,
sure.
so.
if I go bigger balloon, easily have rupture. I
think
guarantee
this
you.
long- This looks pretty good.
I guarantee you guys. And if I rupture and I have to put a graft, so the risk of stenosis may be higher than
Very high after two steps.
now.
50% in 1 year with draft sense. So
Yeah.
you're way better with this.
I agree. Excellent demonstration.
Okay,
Any final
yeah.
remarks from you guys?
Yeah, I
All right,
think
thank you
Ömer,
very much for your
amazing
help and comment, guys. Thank you very much.